Good evening, one and all. This is Shagnik, the designated moderator from Clarinet for this session. Clarinet is very proud to be a part of this webinar as its digital partner. Now, I would like to play a short video of Clarinet.
Hello, ma'am. Can you hear me? With all your permission, I'm starting this session. I will be introducing you and the topic and you can proceed with it.
Thank you. Thank you everyone for their kind patience. As we all know, Clarinet is India's largest live digital CME and doctor-generated medical content platform, which is exclusively free for all the medical practitioners. You all are requested to visit our website www.clarinet.com, where you can watch lots of live sessions conducted by doctors with great expertise all across the globe. We even have MedWiki service, which is a medical Wikipedia, which is exclusive for the doctors to read as well. We are very grateful to this association and this star-studded panel with such highly affiliated doctors to be associated with us. Now, I would like to hand over this session to Dr. Varghese Thomas.
Thank you, Mr. Sagni. Thank you very much for giving us this platform from Clarinet. I hope you will be there with during the session to sort out any technical problems. And today, so I welcome.
And today, ma'am is going to speak.
There is some audio repeat. Okay. I welcome all the participants and I welcome all the presenters, and I find the presenter Dr. Ajit Taragan. Hi, Dr. Ajit Taragan. So I welcome all the faculty. I welcome all the residents for today's program. Today we have a topic discussion on approach dysphagia, which will be done by none other than Professor Shobhana Bhatia. Right now, Professor Shobhana Bhatia is in another program, so she will finish that program and join us. And she has asked us to start the interactive session. That is how we approach 2-3 cases, and then at the far end of that, she will be coming and telling us the theoretical aspect of the approach. So are the presenters ready? Dr. Jerry, are the presenters available? Dr. Rajendra from Global.
Yes, sir. Ready, sir.
Dr. Parag from SIMS. And Dr. Jovida from Medical Trust. Okay. So I'll be showing Dr. Rajendra. Can I see you?
Yes. Yes, sir.
Okay. Now we will. Am I audible?
Yes, sir.
Is there any audio disturbance?
No, sir.
Because there's a heavy rains and my windows are open. That's why I'm asking. Okay, Rajendra, proceed.
Yes, sir. A 43-year-old female homemaker, difficulty in swallowing for the past 6 months, intermittent central chest pain for the past 6 months.
So this is the history. It is just like a ward rounds. This is what is told by your skilled assistant to you. And you will be asked to elaborate the history. So how will you do? And for each and everything you ask, there should be an explanation.
Yes, sir. First, I would like to inquire about the nature of the difficulty in swallowing, sir. Whether it is for solid dysphagia or both for solid and liquid dysphagia, and then whether it is progressive in nature or intermittent in nature.
Okay. So why do you want to differentiate between solid and liquid or solid and liquid?
Yes,
solid
sir.
or liquid or solid and liquid? Why do you want to differentiate?
To differentiate clinically whether it is mechanical dysphagia or motor dysphagia.
Okay. So how will you differentiate that?
So if predominantly solid food followed by liquid food, it is mechanical dysphagia. If predominantly start with liquid followed by liquid, or as well as simultaneously liquid and solid.
Yeah. So solid more difficult than liquid is more for mechanical. Liquid to begin with, and liquid and solid for motor dysphagia. Okay. What do you want to know the progress?
So progressive dysphagia can be either benign or malignant etiology. So depends upon the type of bolus. If it is Progressive solid state dysphagia with weight loss may be underlying malignancy. Progressive dysplasia for solids, intermediate dysphagia for solids may be due to some esophageal rings or webs or eosinophilic esophagitis.
Okay, esophageal rings probably doesn't progress, but stricture will take a long period to progress, but malignancy a short period to progress. Okay, then we also want to know whether it's an acute onset dysphagia or whether it's an insidious onset. What's the difference between acute onset?
Acute onset
What are the situation where we get acute onset of dysphagia? That means yesterday the patient was all right. Today patient is eating something and feeling that there is dysphagia.
food bolus impaction.
Okay, good. Food bolus impaction.
Pill-induced
All causes of food bolus impaction. What are those? What are the usual causes of food bolus impaction?
Meat impaction. Meat.
What? No, that is what get impacted. But what are the causes or the diseases in the esophagus which will precipitate the problem? That is food impaction.
Stricture of esophagus.
Okay, stricture of esophagus, which was not that significant enough to cause routine dysphagia, and suddenly this happens. Okay, agreed.
Eosinophilic esophagitis.
For rings also, which may not be that severe to produce dysphagia on a day-to-day basis. So there may be mild narrowing, allowing ordinary food, and the narrowing may not be more than 14 millimeter. That's why they don't feel the dysphagia. The diameter may be above 14 millimeter, but when they take some bolus, especially of meat, it gets stuck and it won't be able to go down. That produces. Okay. Then another condition, even in the absence of stricture, is eosinophilic esophagitis. Eosinophilic esophagitis are also known to produce food impaction. Okay.
Shatsky ring and web.
Rings. He has already mentioned. Welcome, ma'am. Welcome.
Shatsky ring and web.
Yeah, rings, strictures, growth, and eosinophilic esophagitis, verbs, etc. So now you get the full history. Dr. Rajendra, Jayanti ma'am, you can add anything else.
Web.
Okay.
Yeah, verb,
Esophageal
rings, strictures, growth, and eosinophilic esophagitis. Okay, Dr. Rajendra, go through the remaining part of the history.
Dysphagia for liquids, which is insidious onset for the past 6 months. For solids and liquids for the past 3 months. Symptoms more on some days and less on some days. Slowly progressive over the past 6 months. Intermittent chest pain and mild back pain spontaneously and sometimes during swallowing relieved within 3 to 5 minutes. No exceptional chest pain or breathlessness. She wakes up from sleep occasionally around 1 to 2 a.m. due to cough since last 1 month, and she goes to sleep after about 3 minutes later. Weight loss approximately 3 kgs in the past 6 months.
So from this, do you require any further points, or from this can you arrive at a diagnosis? So this is how old is she? She is 43-year-old and having symptoms for 6 months. And all symptomatology written here. What are the dominant symptoms?
Dysphagia and chest pain.
One is dysphagia,
And chest.
both for solids and liquid, and chest pain. Okay. So do you have a pathophysiological explanation? Do you have a syndromic diagnosis?
Sir, dysphagia most probably due to motor dysphagia because long-standing duration associated with chest pain, and it is for both solids and liquids also, sir.
So okay, 6 months for solids and liquids.
Yes,
How do you explain her chest pain? How do you explain her cough? She wakes up in the middle of the night and suffers from cough in the middle of the night. So what does it mean?
Because of regurgitation of the food.
So you mean this a regurgitation from where?
From esophagus, sir. Already.
Good. Okay, good. What are the other situations where there can be regurgitation and cough at night?
gastroesophageal reflex.
Yeah, classic gastroesophageal reflex also. Okay. Especially in children. So she has three sets of symptoms: dysphagia, chest pain, and cough, which is probably due to regurgitation. Why chest pain? Is it typical?
Usually chest pain lead to footballers.
Now, what are the situations where you get dysphagia and chest pain? And find out whether it fits in with it. Okay. So the moment you hear dysphagia with chest pain, a list of DD should run through your minds. And then you should apply the most likely a diagnosis along with the other symptomatology which fits in with this case.
Yes, sir. Dysphagia with chest pain. One is achalasia cardia, esophageal, eosinophilic esophagitis.
Pardon?
Eosinophilic esophagitis.
Okay, so motility disorders like achalasia, all the type 1, 2, and 3 can have, and then other motor disorders of the esophagus can also produce dysphagia and pain. Okay, common conditions. Eosinophilic esophagitis, we all learned the theory, but practically we never see it, no? I have not seen a case to my satisfaction yet. So what are the other common causes of pain and dysphagia? Suppose somebody has pain during swallowing. What do you call that?
Adenophagia.
So what are the most common causes of adenophagia in your ward or in your OPD?
Candidiasis.
Is that the most common cause? It's not uncommon. I think I would say reflux esophagitis will be the most common cause of adenophagia, no?
Yes.
Okay, then moniliasis, I agree. Anything else? The severe intense chest pain. Patient was all right yesterday. Today the patient has got severe adenophagia.
Distal esophageal spasm.
No, that does not happen all of a sudden on one day, no? I would say the patient was perfectly all right. Patient woke up next morning and tried to swallow something and intense chest pain and dysphagia. What is that symptomatology? Classic of. This is, and I will give you one more clue. Patient took some tablets.
Pill-induced esophagitis.
Yeah, pill esophagitis. What are the usual causes of pill esophagitis? Someone else is. Somebody is making a lot of noise. Doctor, can you just mute? Sagni, can you mute doctor?
Yes, sir. Yes, sir. Yes, sir.
Okay, Rajendra. So what are the usual causes of pill esophagitis? What are the usual drugs incriminated?
Oral iron preparations.
Most
potassium
common,
chloride.
the notorious one is doxycycline. Okay, and nowadays it is another specialty which causes maximum problem. Which department? Orthopedics.
Bisphosphonate use.
Yeah, biphosphonates. Okay, and tetracycline, doxycycline, potassium chloride, biphosphonates. There are many drugs, but the two common would be doxycycline and biphosphonates. Okay, now I'll go to the next slide.
I just.
Okay, Jayanti ma'am, please.
Yeah, so can it be a mediastinal pathology, this patient? You can hear me?
Yes, ma'am. Yes, ma'am.
We did not cover the complete cause of painful dysphagia. There are many conditions.
What are the causes? How can you just say it's only motor dysphagia? What are the other causes? Can it be a mediastinal pathology? Neurofibroma, slow growing tumors. Because the patient has got pain.
Hello.
Yeah, Dr. Rajendra, are you listening?
What are the conditions?
Jayanti ma'am has asked you, can it be because you said the pain is due to achalasia or motor disorder of the esophagus? Jayanti ma'am is asking you, can it be due to other conditions in the mediastinum, like a tumor which can compress on the esophagus or infiltrate the esophagus and produce pain and dysphagia?
Yes, sir. It can be, sir.
So
And
theoretically it is
What are
possible,
the tumors?
but in this
What are the
case,
tumors?
yeah.
What are the tumors? What are the tumors? Progressive, 6 months, and that is causing it will cause chest pain. It will have radiation to the back. Can it be a cold abscess in the mediastinum? You have to have a wide differentials.
yes, ma'am.
The case will not be so simple. You need a wide differential. It can be anything within the lumen, it can be in the wall, it can be outside. So we have seen patient bronchogenic cyst presenting like this. We've seen patient neurofibroma present like this. We've had patients with the cold abscess presenting as dysphagia. They all present as extrinsic compression. We'll have a progressive nature. We'll have all the symptoms that you described, and there will be radiation to the back. And it be, if you have not examined the spine of this patient, you've missed the diagnosis. So when there's a cold abscess and there's a pot spine, and there's a pot spine, and you've just missed the gibbous, you're likely to miss the diagnosis. You're able to hear me?
Yes, ma'am. Yes, ma'am.
So you have to keep all these differentials in mind. Thymoma. Recently I had a patient of thymoma presenting as dysphagia. So in a patient like this, the one important thing that I would like to just see, when we ask colloquially, do you have difficulty in swallowing? For them, it is only swallow is just the act of passing on the bolus into the oropharynx. That's all. But what you should ask them is, when you take the food, does the food go down? Or you need water to push the food down? That is what is the swallowing defect. If you have not asked a question, they will say, I have no problem in swallowing. And then all the other rest of the history comes out. So you'll have to give one direct question of this, that you're able to swallow, but after swallowing, what are the problems that you encounter? So how will you differentiate oropharyngeal dysphagia?
Oropharyngeal from esophageal dysphagia. That is the question.
History-wise.
Sorry, sir, ma'am, voice is breaking.
Yeah, ma'am, your voice has got broken.
Yeah, but the internet is weak. I can't help it. There's a problem with the internet.
Okay, how to differentiate between an oropharyngeal transfer dysphagia versus an esophageal dysphagia? That is a question from history.
Yes, sir.
Actually, Shobana ma'am will be covering it in great detail, but you can tell it.
Patient presented with cough will attempt to swallow, or patient may present with nasal regurgitation of the food, or associated with any neurological symptoms, favors towards oropharyngeal dysphagia.
Okay, the first and foremost is that the initial act of swallowing, the food bolus which is in the mouth, which has to be pushed down, no? Yes. So the patient can feel the initial pushing down, the initial act of the swallowing is the one which is affected. The esophageal one, you will say, I can actually swallow, but the food gets stuck somewhere lower down. Okay, that is how they say, the esophageal dysphagia. Plus all the other points which you said are, like for example, nasal regurgitation. What does nasal regurgitation suggest? What exactly is the pathophysiology?
Bulbar muscle paralysis.
The soft palate is not opposing against the posterior wall of the larynx. Not okay. So the nasopharynx is open to the oropharynx and food enters the nasal, that is nasal regurgitation. You said about choking and cough on attempted swallowing. What does it mean?
Weakening of the pharyngeal muscles.
The inlet of the larynx is not able to close.
Yes.
Okay, inlet of the larynx is not able to close during the act of swallowing. It's a very complicated mechanism. The larynx will be lifted up, the aryepiglottic fluid will close, and then that prevents the flow of food and fluid into the larynx. Okay, so that mechanism when it is paralyzed. Okay, so then if the vocal cords are paralyzed, you will get hoarseness of voice. Hoarseness of voice. Okay, the hoarseness of voice, choking or cough on attempted swallowing, nasal regurgitation, and if the tongue muscle or if the masseters are paralyzed, etc., the patient will also may complain of difficulty in chewing, drooling from the side of the mouth. Okay, all those things will be there. Shavanya ma'am, welcome. You have come back. We are glad that you are there. We have just shown a case just to keep them engaged.
Yes.
So we just proceed with the case and then quickly come to your session. Okay.
Okay. So you want to finish the case?
No, we will stop at this level.
So
And
can I see the history once at the back? So whatever you have covered, can I just see the quick slides? Okay, come next. Next.
What are the cranial nerves? What are the cranial?
Next. Okay, next. So I'm just quickly going through. Okay.
we haven't showed this. Okay.
Okay.
We
Fine.
only reach up to this level. Okay, now you can take over. I will stop
Okay.
sharing the slides. You can start sharing your slides, ma'am. Welcome today. So welcome, Shobna, ma'am. Thank you for joining us in spite of having a very busy schedule. Professor Shobna Bhatia is the senior consultant at Sir H.N. Relay's Foundation Hospital at Mumbai. She was a former professor and head of gastroenterology at KEM, and she has been a chief editor of Indian Journal of Gastroenterology. There are many accolades to her credit. So a warm welcome to you, ma'am, and please start your class.
So first of all, thank you, Dr. Varghese Thomas, for asking me to come over. And the first admission that I'm going to make is I'm going to only talk about symptoms. I'm not going to talk about detailed analysis. I'm not going to talk about investigations and show you pictures. Okay, so I'm just going to share the slide, and that is, where is that?
Share screen.
Yes. Okay, so we'll start with this. Can you see my screen?
Yeah, we can.
Okay.
You can put it into full screen if you would like to.
Yes, play. 1 minute, I think this is play.
Even otherwise, it is very well visible.
Yeah, so is it so correct?
Yeah, now it is perfect. Perfect.
Okay, fine. So you've already introduced me, so I don't have to go through it. Now, this is the esophagus the job is exactly like that of a river. So first, it transports food from the mouth to the stomach. Second, the lower esophageal sphincter prevents gastroesophageal reflux. The upper esophageal sphincter prevents aspiration. And of course, dysfunction can lead to several symptoms. So let's start with the esophagus and its anatomical parts. Remember that even though we talk of dysphagia as an esophageal symptom, it's good to remember that the first part of eating starts with chewing. And if therefore, we also have to include examination of the mouth when you look at a patient who says he has dysphagia. So the cricopharyngeus muscle is about 14 to 16 centimeters from the mouth. There's the cricoid cartilage. Then there is the cervical part of the esophagus, which is completely skeletal muscle. There are these constrictors, which is the bronchoaortic constriction, means the bronchus and the aorta. And the next part is the diaphragm, which also constricts the lower end of the sphincter of the esophagus. At the GE junction, you also have the diaphragm as well as, and then the esophagus goes down into the abdomen and joins the stomach. So this is just to remember that there are many causes of dysphagia, and we have to know the anatomy before we start talking of other things. So what is dysphagia? Now, every patient that you see will have a different description, and I'll come to those things sometime in the history. So dysphagia is a sensory symptom, and it is the feeling of food sticking after or during swallowing while the food is traveling from the mouth into the stomach. Sometimes this is not a transit symptom, but it is a perception of bolus, which is lodging in the chest. And sometimes the patient may just say that he has fullness in the chest rather than actually saying he has dysphagia. Many patients turn around and say, no, I don't have dysphagia. And the symptom that you then ask is, do you keep drinking water with every solid bolus that you take? Or importantly, do you take a long time to eat? A lot of patients will tell us, or rather the relatives will tell you, that this patient, we tell him beforehand, you start eating half an hour before so that we can get up together from the meal. Otherwise, when everybody is finished, he's still at the table and we have a long time to clear the kitchen after that. So these are important symptoms to ask. So just to understand that we know that we can divide dysphagia or classify it into two types. The first part is transfer dysphagia. The second is the transit dysphagia. What we do mean by transfer? The food is transferred from the mouth across the upper esophageal sphincter into the esophagus. And here the most important causes are neuromuscular rather than anatomical. The pharynx and the upper esophageal sphincter have a very big role to play. And sometimes at these points, there may be odynophagia because there is inflammation in the upper esophagus, in the pharynx. In the esophagus, most of these abnormalities are because of the lower esophagus, the lumen or the sphincter or the gastric fundus. So we always look at the gastric fundus during endoscopy in a patient with dysphagia. And traditionally, we classify it as mechanical or motor. What happened? Okay. Now, just to go through the stages of swallowing, we know there is the oral stage, the oropharyngeal stage, and the esophageal stage. The oral phase is completely voluntary. Okay. And swallowing, I'm just going through this. Swallowing of the oral phase is voluntary. Mostly we swallow because we are eating food for our nutrition. And we take it so much for granted that we don't realize that when we are eating food, we're watching television, we're talking to friends, and don't even realize that you are chewing or not chewing your food. The second part, reason for swallowing, is the subconscious one, which there is some saliva that comes into the mouth that is normally secreted, and we swallow approximately once per minute. This frequency decreases during the night. And here, the reason for this swallowing is that it is a housekeeping mechanism for the mouth to be cleaned. And it is also a reflux clearing mechanism because some amount of acid keeps coming up. And the saliva, which is alkaline, will neutralize the acid that spontaneously comes into the esophagus, even in normals. The other one is a reflexive pharyngeal swallowing, which is basically an airway protective mechanism against aspiration. And I must tell you that I don't know whether you have noticed, whenever you cough, it is always followed by a swallow. So that this is the reflexive pharyngeal swallow that we take. There is not much bolus in the mouth. We just have a cough instinct. It may be a dry cough, but after some time, we have to swallow because this is an airway protective mechanism against aspiration. So the stages are the preparatory stage, the oral and the pharyngeal stage. Preparatory and oral stage are voluntary. Pharyngeal stage and esophageal are involuntary stages. You cannot reverse these stages. So what is oropharyngeal dysphagia? Oropharyngeal mechanisms basically are there for airway protection and normal transit into the esophagus. And you look at the mouth functions, which are the tongue, the pharynx. You also have to evaluate relaxation and opening of the upper sphincter, airway closures, that is the larynx and the velopharynx, sensory function and coordination. So the major symptoms of oropharyngeal dysphagia are three. Difficulty in initiation of a swallow, what we traditionally call as transfer dysphagia. aspiration or cough during swallowing, nasopharyngeal regurgitation while swallowing, not after the swallow is over, not after the meal is over. And these are the cardinal symptoms of oropharyngeal dysphagia. So this is an important part. When we look at this transfer dysphagia, when you ask the patient questions, look for certain things. Is there a nasal twang in the voice? Is there also dysarthria, diplopia, or dysphonia, which tells us that this is a neurological cause of swallowing? Importantly, ask for drooling of saliva. Whenever there is absolutely total dysphagia, especially if it is oropharyngeal, the saliva will not go down and cross the upper esophageal sphincter. And therefore, the patient will say he has drooling. Sometimes the patient doesn't complain. He will say that in the morning when he gets up, there is a lot of saliva lying on the bed. Ask the patient whether there are muscle twitches or fasciculations. And of course, look for signs of myasthenia or symptoms of myasthenia, that the initial part of the swallow is absolutely normal and the patient starts getting tired and starts getting transfer dysphagia after half the meal is over. Ask for focal neurological deficits and ask whether the patient has a feeling of residual food in the pharynx. Sometimes this is a symptom which is neurological. Sometimes it's a symptom that is the patient is actually, there may be an aspiration occurring, but the cough is preventing it, but some food goes and sits in the pharynx. And sometimes it is also a symptom with Zenker's diverticulum. The next symptom to ask is about poor mastication. The patient may not complain about it, but ask them whether they have difficulty in chewing. And in older people, ask whether they have recently had their teeth removed and they are awaiting a denture, or that their denture is new and they are unable to adjust to it. All these things will lead to poor mastication, and the bolus size is fairly large, and therefore the patient cannot swallow a large sized bolus. The second thing is poor saliva. Sometimes the mouth is completely dry, as in Sjogren's syndrome. And whenever we try to chew food, saliva tries to make the bolus soft, and it combines the bolus into one big piece, and therefore we can swallow it in one big go. When there is no saliva, this function is not there, and therefore the patient complains of transfer dysphagia, and what you have to look for is a decrease in saliva. Sometimes the patient may say he has associated halitosis. Halitosis and immediately coughing out of food after the swallowing or after the meal. Is somebody talking? Can we mute everybody? So halitosis may be a sign of a Zenker's diverticulum where food has collected there and is getting fermented because of the bacteria, or it sometimes may be even there in patients who have a large dilated esophagus where food there is a lot of stasis of food. Another sign of aspiration is recurrent pneumonia. We see this even in patients with reflux, but when patients complain of upper esophageal symptoms, also look for pneumonia. Okay. So now, as we age, I'm saying as we because I am already aging, there are certain abnormalities that occur in the upper part of the esophagus and the pharynx, which also delay swallowing, and these can be all part of aging rather than disease. So in older people who have Parkinson's, who have neurological deficits, you will see this, but you can also see it in otherwise normal people over the age of 85 or 90. And we are beginning to see these kind of people now. So in the broad categories of oropharyngeal dysphagia, You can have central nervous system defects, structural lesions, muscular disorders, pharmacological agents, which can give rise to oropharyngeal dysphagia. And nowadays, there's even patients who have severe lung disease that can be oropharyngeal dysphagia. Just a tip that patients who have COPD will be on inhalers which contain corticosteroids. Very often they will develop candidiasis in the mouth. Sorry. Very often when they develop candidiasis, they will come with odynophagia. And therefore we have to look at the throat in these patients. Okay, now what do we do in these patients? If there is, which would you do first? If you want to see residue aspiration, fluoroscopy with some liquid is the best choice. Endoscopy is also a good choice. Now, as gastroenterologists, we find that we are not good at looking at the upper sphincter and the pharynx during swallow. So we usually bounce these patients to the ENT. Now, the upper sphincter quite often is an orphan organ. Neither the ENT are good at looking at it, neither are we gastroenterologists. So I would suggest that, you start looking at the upper esophagus, especially not during regular endoscopy, but when you're doing a transnasal endoscopy, also start looking at the larynx and its movements during upper endoscopy so that you can familiarize with yourself with these parts and learn about upper esophageal dysphagia, because these are patients which will keep on coming to the gastroenterologist eventually. Finally, we come to the proximal esophagus part. I'm talking only about the oropharyngeal dysphagia. In the proximal esophagus, there may be mechanical lesions. Motor disorders usually do not affect the proximal esophagus because it is skeletal muscle. Sometimes disorders like motor neuron disease can cause dysphagia here, but it is usually the mechanical lesions like a ring, a Plummer-Vinson, sometime an eosinophilic esophagitis, a proximal stricture. The inlet patch hardly ever gives rise to symptoms. So if a patient comes with dysphagia and you incidentally find an inlet patch, please don't try to go and repair it immediately or do some kind of resection, because that is not going to solve the problem of the patient. Inlet patches are absolutely benign and they do not cause any problems. And malignant causes, of course, we have to know about. Now, when we talk of proximal dysphagia, we also know that patients who have a disease in the distal esophagus, in the fundus, can also complain of dysphagia, which is localized to the upper esophagus. But this is dysphagia. This is not transfer dysphagia. This is a transit dysphagia. So dysphagia always localizes above the lesion. If the lesion is at the LES, it may localize at the LES, in the middle third, or in the upper esophagus, and so on and so forth. So when you look at disorders of the smooth muscle part of the esophagus, you ask certain questions to the patient, and this is what I'm going to concentrate on now. What are the questions you ask? Is this sudden onset or is it a slow onset? So sudden onset also, there could be patients who have previously some minimal dysphagia occurring once in a week, twice a week, occasional choking, and then come with sudden onset dysphagia. There can be a slow onset, which can be progressive or non-progressive. And this is the classical smooth muscle dysphagia that we talk about. Now, esophageal symptoms are, besides dysphagia, heartburn, chest pain, squeezing, chest, which is squeezing, and it can be exactly like a myocardial infarction. And the next one is globus. Now, how do we differentiate globus from dysphagia? Globus never occurs during a meal. Dysphagia always occurs during a meal. So any sensation that the patient has afterwards, saying that I feel that there is something stuck here, but he's not eating at that time, in that case, it is called globus. That word globus hystericus has been taken away because we know that globus can be associated with a lot of motility disorders, and therefore the word globus pharyngeus is now used. Heartburn, when it is associated with dysphagia, could be due to reflux, which is the most common cause of dysphagia. It is usually the classical heartburn that you see in reflux patients. However, patients who have a lot of food which is stuck in the esophagus, as in achalasia, the food is fermented, broken down, has a lot of stasis, the lactobacilli are there, the lactic acid is produced, and patients can have mild heartburn, which is similar to the one you see in reflux, except that it is a continuous heartburn. It is not only after meals, and it may be occasionally fluctuating, and it's only very mild. So what are the associated symptoms of the dysphagia patients? Now, in patients who have dysphagia, the regurgitation that they have is never sour because the food has not yet crossed the lower esophageal sphincter. So there is no acid that is mixed in the food. Therefore, the regurgitation is of undigested or partially digested food. So therefore, when you ask questions, ask them whether the symptoms are the regurgitation fluid is sour versus bland. Here, there is sometimes a problem. If the patient has reflux and is regurgitating, and the patient is taking PPIs, that regurgitant fluid will also be bland. Secondly, if the patient has fermented food in the esophagus, there might be a mild sour taste to the food, and sometimes we can make a mistake here. Ask the patients whether there are nocturnal regurgitations. Nocturnal episodes of regurgitation are usually seen when there is a large residue sitting in the esophagus, and these nocturnal episodes are associated with nasopharyngeal regurgitation. Patients of achalasia with large esophagus, when they lie down, all the food starts coming up. This you don't see in patients with reflux somehow. You see it mainly with achalasia, very rarely with malignancy. Now, regurgitation, which is coming from the esophagus, is never preceded by retching or vomiting. It is a spontaneous regurgitation. And if there is weight loss, of course, we have to look for mechanical lesions or malignancies. So in the patient with dysmotility, what are the questions we ask? Do you cough or choke when trying to eat? That is classically an upper esophageal symptom. What do you have trouble eating, solids or liquids? So a person who has consistently solid food dysphagia, if it is intermittent, going on for a long time, start thinking of Schatzki's rings or any other ring in the esophagus. In motor dysphagia, usually the patient has solid plus liquid food dysphagia. Now here, if your patient is taking small amounts of liquid, there is no dysphagia. But if they try to drink a glass of water very rapidly, just as you would do when you're very thirsty, you've come somewhere from outside, you go home and you quickly drink a glass of water, that is when they suddenly feel that the bolus is absolutely stuck, and then they stop drinking water. So when does it happen? Is it with every meal? Is it intermittent? Is it only with certain foods? So which certain foods? Then you start asking for symptoms like, whether they have associated atopy, like the patient would have eosinophilic esophagitis, if they have recurrent allergies, if they have repeated, colds and coughs, or they have asthma, then in that case, try looking for eosinophilic diseases as a reason. Where does the food stick? I've already discussed that. If it is in the neck, the xiphisternum, or in the lower third of the sternum. Regurgitation, bland or not, whether there is heartburn. When did it start? Now, when did it start is a very important question that many people don't remember. Because when these diseases are slowly progressive, that is motor diseases, they suddenly notice it one day and then suddenly everybody will tell them, yes, you've changed the consistency of your food. You've started eating more slowly. You're trying to chew more. Whereas when this is rapidly progressive, they can usually say few months or few weeks. So this is something you can ask. Is it getting worse? Is it getting worse over months, which means it's likely to be a mechanical lesion? Is it getting worse over years? Then in that case, it could be mechanical, especially like a peptic stricture, or it could be a motor disorder. Today, very important to ask whether there is ingestion of opioids. Most opioids, patients will come with dysphagia of some sort. And if you do the endoscopy, it's not likely to yield any results. Manometry might show you exactly like achalasia or diffuse esophageal spasm. So before you go and do anything, intervention in patients with either achalasia or diffuse spasm, please ask for a history of opioids. The manometry looks absolutely similar. So coming to the classical things that you see in the textbooks, motor versus mechanical. We said that motor dysphagia, solids and liquids simultaneously, that is there in the textbooks. But many of my patients say that they intermittently get solid food dysphagia. They might choke up occasionally, but when they drink large amounts of liquids, they get a problem. Initially, they can wash the food down with liquids, but eventually the fluid starts collecting. So mechanical dysphagia we know is progressive, solids early, liquids later. The course is slow. In mechanical dysphagia, it is intermittent, rapid, depends on the disease. The duration is over years versus short. Improvement versus maneuvers. So when you do a Valsalva maneuver, you increase the intrathoracic pressure. That pressure then overcomes the lower esophageal sphincter pressure. Same thing with repeated swallows. Whenever you do repeated swallows, the pressure in the esophagus always increases. And when you try to straighten your back, that also helps. And of course, mechanical dysphagia is never helped with any of these maneuvers. Chest pain in mechanical dysphagia, you see only when there is periesophageal or extraesophageal infiltration, large lymph nodes. So that's a cause not to be forgotten. Many patients with sarcoidosis, tuberculosis may come with dysphagia. And on a chest X-ray or a CT, you might find multiple lymph nodes. And that can give rise to chest pain along with dysphagia. Whereas motor dysphagia, the chest pain, as I said, is exactly like a myocardial infarct. It comes suddenly, sometimes is a long-standing thing. Sensitivity to hot and cold temperature, you see only in motor dysphagia. You don't see it in mechanical dysphagia. This is because very cold food can induce spasm of the esophagus, and hot food, the patient just becomes sensitive, that's all. Weight loss is not prominent, but may occur because the patient starts decreasing his intake, seeing that he's embarrassed by everybody eating in the surroundings in 10 minutes, and he doesn't finish his food, so then he starts decreasing his intake. And that is when they have a mild amount of weight loss. Secondly, whenever they have a lot of regurgitation and they start thinking that they're vomiting, they decrease their intake, and that is when patients of achalasia would get weight loss. So, coming to other histories that you will ask. So, this is you ask for heartburn, regurgitation, drugs, histories for NSAIDs. This is for acute dysphagia. Antibiotics like doxycycline, allergic rhinitis, asthma, corrosive intake. Do not forget this. Corrosive can also cause upper esophageal dysfunction because the corrosive may actually cause burns of the upper esophagus. Radiation esophagitis, esophageal surgeries, and Raynaud's phenomenon or dryness of the mouth. Okay. Symptoms of complications of dysphagia. So if the patient has a mechanical dysphagia like malignancy, there may be recurrent chest infections because of aspiration, which can occur even in motor dysphagias. There can also be sore throat because the upper esophageal sphincter starts getting involved. There may be mild aspiration, coughing, wheezing, chest pain, change in voice, weight loss, and dehydration when the patient is unable to take much when there is total dysphagia. Okay, this is how we grade our solid food mechanical dysphagias. We all know this classification. I won't go into it. Quickly, I'll touch upon acute dysphagia, where the causes are extremely important. Today, the most common cause I see is medication. The other common cause, is neurological dysphagia, stroke, tetanus. So I remember many years ago, somebody referred me a patient saying that this patient has suddenly stopped swallowing. Can you just do an endoscopy? The patient came, and what I saw was the classical smile of a tetanus patient. And I knew that this patient's swallowing was not going to be treated with an endoscopy. Sent him to the tetanus ward. So today, tetanus is very unusually seen. So for those who have not seen patients of tetanus, if you did not have tetanus wards or did not have access to tetanus patients, please go and see videos of tetanus patients. You don't want to miss these patients and take them up for even barium swallows. They'll aspirate. They will not be able to swallow it. So the other interventions like sclerotherapy, which we used to do in the past, we still do it sometimes. Banding can give rise to dysphagia. Esophageal dilatation, post-dilatation, the patient can have dysphagia. Now this, I will tell you all that if you have done an achalasia dilatation, the patient may develop an intramural blood clot, which will give rise to severe dysphagia for the next 2 weeks, along with severe pain. So if the achalasia dilatation is done, make sure that there is no perforation before you discharge the patient. Second is EOE, Candida, herpes simplex virus can cause inflammation of the esophagus. Because it is acute, these patients may also have severe odynophagia, especially if the oral pharynx is involved. As far as eosinophilic esophagitis is concerned, acute dysphagia occurs when there is a food bolus impaction. And the patient may have noticed only mild dysphagia previously and now has sudden onset dysphagia. So I can tell you all, I wish I had got the pictures, which I didn't bring today. I recently had a 50-year-old man who came with sudden onset dysphagia and drooling and no neurological symptoms. When I went into his history, he said over the last 3 years, he has been having mild choking, but no dysphagia. And intermittently, he had dysphagia when he had large boluses of rice. The CT scan reported a polypoid lesion in the lower esophagus. When we did the endoscopy, there was a Schatzki's ring. So if there is a food bolus impaction, even a ring can present with acute dysphagia. So we have to keep in watch about these things. As I mentioned, radiation, foreign bodies, of course, if the patient has swallowed a large mutton bolus or a bone, be careful about these because there can be perforation when you're trying to remove them. Of course, corrosives, which we are well aware about. So if a patient comes with dysphagia, what do? Ask whether there is a difficulty initiating a swallow, coughing, choking, nasal regurgitation, or the sensation of food getting stuck in the esophagus, which is a few seconds after initiating the swallow. The upper esophageal sphincter opens for less than a fraction of a second to allow the bolus to go across. So if it is a few seconds after the swallow is taken, it is more likely to be an esophageal dysphagia. So esophageal dysphagia, solids and liquids. Only solids, look for mechanical, non-progressive, esophageal rings, eosinophilic esophagitis. Progressive, chronic heartburn, look for a peptic stricture. Older adults, weight loss, anemia, esophageal cancers or cardiac cancers. Solids or liquids, motor disorders, intermittent, primary esophageal motor disorders or secondary ones like scleroderma, reflux. Again, progressive can be scleroderma also and achalasia. So this is another way of looking at it. What do you do? Do you do a barium swallow first or do you do an endoscopy first? So there are proponents on both sides. Today, because we have easy access to the endoscope, and for those who have pediatric endoscopes, endoscopy is a good choice, except when you suspect that there is neurological dysphagia, aspiration, or when you're suspecting a Zenker's diverticulum. Because in Zenker's diverticulum, it is very easy to perforate the diverticulum and easily miss it. So if you're looking for a barium swallow, it is mainly to look for a motor disorder or for diverticuli. If you're suspecting a stricture, which you have already diagnosed on the endoscopy, or a patient has come with, say, corrosives, then in that case, do the barium to map the stricture. Those are the current indications of a barium. And the rest of it is dysphagia to solids alone. As I mentioned, you can look for webs. Extrinsic compressions are something that we are not good at picking up during endoscopy unless we see that it is compressing the lumen. And then if there is nothing in the lumen, then you can decide whether you want to do a manometry or treat the patient as GERD if the patient has symptoms of GERD, and then do further evaluation. Thank you. So Dr. Varghese.
I was on mute mode. Okay,
Yes.
thank you, ma'am. Thank you for that wonderful talk on the various aspects of dysphagia, and it is very useful. I'm sure it will be very useful for the students, and they would have thoroughly enjoyed this. Ma'am, shall we allow some more case discussion after this? Would you like to have? And we have time up to 9:30.
So
Am I audible?
Jayanti, you want to discuss something more on the symptoms, or we can go to the case?
You can hear me?
Yes,
Yeah.
yes.
Okay, because this thing was not all right, internet. So what I was thinking is, like the cases that we see, and we have all types of examiners around. So few questions that have always been asked is, Shobna has covered almost everything of the various phases of swallowing is number one. Number two is, just by the act of swallow, can you identify the site of the lesion? That's the usual common question. Then you have the cranial nerves. Which are the cranial nerves that are involved? These are all, the erstwhile examiner's solid questions.
Yes.
And then they put up a barium swallow, which shows a small stricture in the upper third. And then they ask what will be the first symptom that this patient is likely to have. You're not able to cross the stricture. How will you do a balloon dilatation? These are all the classical cases that I've come across.
Correct.
And then the next question is, would you do an endoscopy or would you go ask for a barium swallow? So which one would you consider first? When will you consider barium swallow as the first line of evaluation versus upper G endoscopy? So most of the textbooks always say, no, barium swallow is a roadmap. So then immediately the examiner will say, when you have an endoscopy, why would you like to do it? So these are some of the classical questions. And I think don't miss the mediastinal masses. retrosternal thymomas and goiters. Then we've seen retropharyngeal cold access Fundus dysphagia, neurofibromas, bronchogenesis. All these are some of the causes. So even though it is progressive, gist tumors, huge gist tumors, exophytic tumors presenting as dysphagia. So I think you should have a wide this thing, and corrosive stricture. I think if there's a case on corrosive stricture, you can take it up for discussion, because that's something where they always falter. They're not able to discuss. We had in the recent exam, one of the centers, corrosive stricture, and the candidates could not answer any of the questions related to corrosive stricture. The usual question, complex, simple, even there they falter. And basically, how will you dilate? What are the instruments you keep ready for dilatation? Eckhart scoring, how do you assess post-dilatation? What's Eckhart scoring? These are some of the questions that are asked. If you have any classical case, you can take up. And as I told right in the beginning, don't, whatever is the language of the patient, don't say, they say in Tamil, are you able to swallow? Simple. So that patient will say, yes, I'm able to swallow.
I can.
But you have to just ask, as Dr. Shobna clearly mentioned, when you ask, when you take food, does the food go down into the stomach or there's a hold up? And then she said, that is actually my problem.
Yes.
I'm not able to push the food down and I need water to push down. That is what is most important. So when you just ask, are you able to swallow in whatever language? No? Aap khana kha sakte ho? And they'll say yes, because you're able to roll the food and it goes down. Beyond that, if they're able to push the food down with water, that means there's some problem. There's a mechanical dysphagia. So this is something in your day-to-day practice that you're likely to miss. And then it may be a CA stomach with dysphagia. So these are some of the important conditions. Then of course hernias and all, as they put the barium spotters, they'll ask for hernias, paraesophageal hernia, whatever clinical presentation. And they will have, some of the centers have their manometry, HREMs.
Yes.
And they'll ask you to interpret. So you have to be familiar with that. You have to be familiar with the impedance type as well as the regular HREM types. So I will go to the Google or go to at least get to go through some of the centers. Some of you have some tracings and you can show them. You have
Tracing of HRM.
Yeah, so Shobna can just tell some points, about especially about the repetitive swallow, especially when they have impaired swallowing. What is rapid swallow, and what is the complete effect of the rapid swallow is the one that will tell whether it's actually the weak peristalsis or it's a summation of the weak peristalsis.
Okay, so this is the HRM where you see. Can you see my pointer on the screen?
Now we can see whether your pointer is.
My pointer, can you see it?
Move it.
No, because
it's seen.
My black pointer, that white pointer, I think is Dr.
mine.
Thomas. Yes.
Okay. Yeah.
So we can't see.
So what? So first of all, in the HRM, there are three things to note. You see, first is this is time. Okay.
Yeah, we are not able to see your pointer. Sagni, can you allow Professor Shobna to have control over the cursor?
I have something on manometry. Can I bring out those 3 or 4 slides?
Yeah, I can stop sharing and so that you can have your.
Sure. So it'll.
If you am I audible?
Yes.
Shobna ma'am is doing. You can
Yes,
tell me the technique.
If you give the remote control to Professor Shobna Bhatia ma'am, then she can control the screen as well.
Actually,
what I'll do is I'll just bring out some of my old things, and then 1 minute. No, sorry.
I will show it then.
Sorry. No, I'll have to just open out that.
Okay, ma'am, I will actually give you mouse keyboard control.
No, I have the things.
Now you try. You can actually use the mouse and see.
Okay, this is okay now?
Yeah, perfect.
Okay, perfect. So when you look at the manometry, what you see is these colorful things. So the upper red band is the upper esophageal sphincter. The lower band is the lower esophageal sphincter. From below upwards, this is the entire length of the esophagus. So the upper esophageal sphincter is on top, the lower esophageal sphincter is down. And from left to right is the time. Now, you look at these multiple colors, what do they mean? So this is what is called as the Klaus plot. What Ray Klaus had done is he had converted the pressure waves into colors. So when you look at the colors, you just have to remember the colors of the rainbow. Of course, it's a little different here. So remember, this is dark blue. So violet, indigo, blue, and then you merge to green, yellow, orange, and red. And as you get into the darker shades, these darker shades means higher pressures. The bluer shades are lower pressures. The next thing you see is these waves here. So you're seeing these waves. There are suddenly, this is blue and this is green. So blue is low pressure. As you follow this blue low pressure down, actually in this it's not so clearly seen. I can see it on the right side. So can you see this blue, Dr. Varghese?
Yeah, definitely.
Definitely. So this blue, after it crosses the LES, becomes green. So this is deep inspiration. During inspiration, thoracic pressures are low. And therefore, in the esophagus, you see lower pressures. Abdominal pressures are increasing during inspiration, so therefore it becomes green. When you breathe out, the thoracic pressures are high. So this is inspiration, this is expiration. Crossing the LES, during expiration, the abdominal pressure becomes low. So this is one thing that you see, that is inspiration. And if you look at the background, you can make out what is the breathing rate of the patient. Secondly, in the middle esophagus, somewhere you will start seeing these multiple waves. This is actually the cardiac or the aortic pulsations. So aortic pulsations also are transmitted. Whenever the esophagus, whenever we start swallowing, the esophagus longitudinal muscle tightens. Therefore, the esophagus becomes stiff and the aortic pulsations are not transmitted at this point. So if you continue to see these aortic, if you continue to see vascular pulsations here, that means it is a dysphagia lusoria. Okay, because the vessel is so close to the esophagus that it continues to transmit the pulsations. So now when you see this, you see that the upper esophagus sphincter has opened. You see the blue color here, that means the pressure in the upper esophagus has dropped. So therefore, this is upper esophageal sphincter relaxation. This occurs only for the fraction of a second. And then you start seeing this onward peristalsis. As soon as the upper sphincter opens, the lower esophageal sphincter starts relaxing. In the lower esophageal sphincter, relaxation is different from opening. Relaxation means only a decrease in pressure, but there is later on an opening. So this is the point where you measure the relaxation of the sphincter, which we call as the IRP4, integrated relaxation pressure over 4 seconds. In the middle of this, you will also see crural diaphragm contractions. And sometimes when we measure only these if the patient is breathing very fast, then in that case, the crural diaphragm pressures are seen and we tend to believe that this patient has high IRP. So that is a mistake we should not make. Also to remember is that as soon as we start swallowing, breathing is suspended for a fraction of a second. So you cannot see the diaphragmatic pressure here. Okay. Now coming to the parts of the esophagus, said proximal is skeletal muscle. In between the two, where the two muscles overlap, that is skeletal and smooth, there is the transition zone. In the transition zone, the pressures are very low. and sometimes is mistaken as a, thank you, Dr. Varghese. That is mistaken for a low pressure zone or that there is a failed peristalsis. That is not true. It is the transition zone. And then you see the peristalsis. As the peristalsis ends, it merges with the LES and then continues as the LES. Okay, so this is a normal peristalsis. On the right side, what you see is there is a swallow. There is hardly any time for the pressure to develop here. The lower esophageal sphincter has not opened at all. You compare it with the screen on the left. This pressure has remained the same throughout. Okay. And there is a simultaneous pressure wave, which we also call as pan-esophageal pressure, which means the esophageal pressure started in the upper esophagus, went down to the lower esophagus. So this is pan-esophageal pressurization. And therefore, this is a type 2 achalasia. Any other things, Dr. Varghese? So this is type 1, where you don't see any peristalsis. The esophagus is so large that it cannot generate any pressure. So there is hardly any increase in pressure here. There is no opening of the lower esophageal sphincter. And therefore, because this is a very large esophagus, this becomes a type 1 achalasia. Only thing to be careful about is in a patient of scleroderma, you will see the same picture except that there is the lower esophageal sphincter has extremely low pressures and you hardly see any pressure here. But the esophageal body will look exactly like this. So a scleroderma esophagus can look identical to a type 1 achalasia.
Sometimes the S1 segment appears, no? The skeletal muscle. You may see short
Yes,
S1.
it may contract, yes.
Yeah, yeah.
It may contract in scleroderma. So this is the S1, which is the skeletal muscle. That's right.
Yeah.
Secondly, once you have dilated or treated a type 1 achalasia, it can look exactly like scleroderma. So history is extremely important when you diagnose manometry. Okay, this is type 2, which we're talking about this pressurization, which is pan-esophageal. Now come to the type 3. Now type 3, you see a simultaneous contraction where there is spasm. And there is what is called as compartmentalized pressurization. A lot of people get confused with this. What is the difference between compartment and total pan-esophageal pressurization? So compartmentalized means only one segment has been pressurized. See, this is only seen, this pressurization is only in the smooth muscle part of the esophagus. There is absolute spasm. There may be high pressures. Now you look at the lower esophageal sphincter. If you see that the lower esophageal sphincter has not relaxed, it is type 3 achalasia. If the lower esophageal sphincter has relaxed, this is diffuse esophageal spasm. In diffuse esophageal spasm, you will also see intermittent peristaltic waves. So diffuse esophageal spasm is never an absolute compartment pressurization.
That is 20%, no? 20% of the swallows will show peristalsis.
20% of the swallows, yes.
Yeah.
You need more than 2 out of 10 swallows
to
be able to say that this is
yes.
Correct. Absolutely. Next.
I
Is there anything more in motility? No.
No,
Okay.
motility I don't have. I
Okay.
can show one X-ray to them and ask them.
And that you will have to interpret.
No. What is this investigation? That's it. To the students
Let
only.
one of the students answer this.
Oh,
barium isogram.
yeah, what is it?
Timed barium isogram.
Oh, good, very good. So what is it used for? Timed barium solo.
To assess the post therapy resistance. Of
Yeah,
the
objective method of assessing the response of treatment of achalasia cardia. Usually we ask subjectively and ask them how to improve and they say they improve. But these findings may persist for a longer period. Professor Shobhana, after pneumatic dilatation or even after surgery, these dilated esophagus may persist for quite some time, no?
the dilated esophagus is not going to go away.
Yeah.
It's going to remain.
It will going to remain.
But
So,
because we have removed the resistance of the LES, then
Yeah.
we may not see this fluid level after a good dilatation or a
Yeah.
good Hellers or a good poem.
Esophagus, esophagus just remains as a conduit. It
Yes, it just remains as a conduit.
yeah.
But in patients who have type 1, and especially, the sigmoid esophagus, patient will continue to have dysphagia even after you have done the best therapy on earth. And then when you do this barium, you will see that there is still stasis because the esophagus is just not able to push the bolus down. And therefore, you then say that this patient does not will not now benefit from further procedures, will require an esophageal replacement therapy.
Can one of the students take up the question, what is non-cardiac chest pain? This was asked by one of the examiners. What is non-cardiac chest pain? This was in the recent exam.
Parag, Dr. Parag.
What is
Yes, sir.
non-cardiac chest pain?
Okay, please answer the ma'am's question.
Any other causes of the chest pain other than the cardiac causes, ma'am?
Want to expand on that?
Pertaining to
Can
gastroenterology.
Can be.
If we get a hit on the chest also, it can be chest pain. But pertaining to gastroenterology, please explain what is non-cardiac chest pain.
Can be the chest pain arising due to the reflux esophagitis.
Okay. So
Or
pain
can be,
of esophageal origin. Okay.
Yes.
Pain of esophageal origin, which classically happens in one is reflux, agreed.
yes, sir.
Then
Or pain due to eosinophilic esophagitis also can present as pain, sir.
okay. Another important was just now Shabna ma'am explained, no? Motor disorders of the esophagus, no?
Yes.
Actually, a cardiac patient can present.
Yes.
Sometimes,
Can some of the PGs take up this question? How do you differentiate cardiac chest pain from non-cardiac chest pain?
and how much evaluation you do for a cardiac to say it's
Yes.
non-cardiac?
Before you
the
start
viva.
saying that this is non-cardiac.
Yeah. That evaluation to what extent of the cardiac to say it's non-cardiac. These are all viva questions. Shobna, there are some questions in chat box.
Yeah, I'll know. So I'll tell you what.
Can one of you take up the question? It's just how much would you investigate?
So how much to investigate? Can you just do an ECG and say this is non-cardiac chest pain?
We'll need troponin levels also, ma'am. Trops or CKMB level.
Okay. Troponin negative, ECG negative.
Troponin, diabetic patient may not have chest pain at all. Troponin may be high.
Okay, troponin negative and ECG negative. And he comes with the recurrent severe chest pain.
Severe chest pain.
Yeah.
Severe chest pain, sweating.
What do you know next?
So if you ask the history, you will ask for what is the duration of chest pain. If the chest pain is for a few seconds, you can't make out. But if the chest pain is there for 1 or 2 hours, you are pretty sure this is non-cardiac. Because in a cardiac patient, in an IHD patient, if there is severe chest pain, usually it is not more than a minute. But by then, the patient has started getting problems. Secondly, if you give them nitroglycerin or a sorbitrate, both the patients will respond. Because nitroglycerin as well as sorbitrate are smooth muscle relaxants. But the cardiac chest pain will respond almost immediately. Non-cardiac chest pain takes about 10 minutes to respond. But these are just few indicators. Never get misled by this, because a cardiac chest pain patient can die while you are still thinking that, we'll evaluate for esophageal causes. Whereas esophageal chest pain can go on and on, no problem. Okay. There's only morbidity, no mortality with esophageal chest pain. So please read up what is non-cardiac chest pain and how to differentiate the two.
And to what extent will evaluate?
What extent will you evaluate?
After microcirculatory circulation, you still have a non-cardiac chest pain. So that's what is important.
Okay.
So you have to go up to that level and say there's even no microcirculatory dysfunction to say that it is non-cardiac.
Yeah, cardiology will say even if a TMT is negative, they will do angiogram. If the angiogram is negative, they will say non-occlusive coronary artery disease, and they will give nitroglycerin, and the patient will definitely improve. And perhaps they will add some aspirin also to add to the problem. Then so one side the chest pain improve, they may develop reflex pain and other things. Yeah, that becomes a really tough situation.
Tough situation, yes.
Tough situation.
Correct.
Okay, there are some questions, ma'am.
Yeah.
Yeah, so there are some questions. Why is IFP normal in type 2? So these questions, you know, we can have one session, Jayanti, later. We can have, this is all related to motility.
Yeah, we can have
because
a session.
They said probe positioning, how to diagnose hiatus on manometry.
I think we will have a session on manometry as such, because nowadays many centers have HRM, and these graphs are shown during examination, and the student must be able to interpret, and probably they may be asked how to do the test also. So I think we will have
spotters.
a session.
Spotters. They come as spotters.
We will have a session on that.
Yes. So I think we can all contribute to that session one by one. We'll show a few slides every time, rather than a full boring session on motility.
Okay, I will. Okay, I think this is almost we are coming to. We'll conclude. So thanks, Shobna ma'am. Inspector having, I think you are having a marathon session. You are in.
No, so they mixed up. They told me that session was at 6:30. That is why I took it up. Then they last minute said, no, it is at 7:30. So then I couldn't, then I rang you up and told you that there is a problem. Yeah.
Okay. So that's why you told me. So we just filled up with the case, and now I request Dr. Jerry, our coordinator from Kerala side, to say the formal vote of thanks. Dr. Jerry. And I also want to thank all the members who have joined. Dr. Ajit Taragan is here, and he has been very kindful to provide all the latest articles about all the cases and topics discussed. Dr. Ajit, please continue to do so for the benefit of our students. And Dr. Jerry, please. Dr. Jerry.
Thank you, sir. Am I audible, sir?
You are audible but not visible.
Thank you.
Where are you? Okay.
Thank you, sir. On the behalf of residents, I would like to extend my sincere gratitude to Shobana Bhatia ma'am for guiding us through the approach to dysphagia and the wonderful talk. I also thank Dr. Varghese Thomas sir and Jayanti ma'am for guiding us through the case. I thank the ISGK Kerala chapter for organizing such a platform event for PGs and residents. I also thank the academic partner Recurrent for supporting us. Thank you.
Thank you. Good night.
Thank you.
Good night. I will get the video and post the
Thank you, sir.
Video, and you can download it and use it. Saknik, thank you very much, and please share the link for the recorded version of the class.
Yes, sir. Yes, sir. Of course, sir. Of course, sir.
Okay.
We hope to see every one of you very soon again.
Thank you.
Thank you very much. Bye.
Good night.
Good night.
Good night.
Good night, sir.